Deukmedjian, the CEO and founder of Duke Spine Institute. We are getting ready to perform our second surgery of the day. This patient has, again, back pain and left leg pain. She has several issues with her spine, but the most notable issues are she has an annular tear with a herniated disc at L3-4, L4-5 that are causing her back pain. There is also a spondylolisthesis at L4-5 that we would call a grade 1 to grade 2 spondylolisthesis. Now, we're not going to be fusing her spondylolisthesis today. We're only going to be performing the Duke laser disc repair. For those of you who don't know what the Duke laser disc repair is, it's basically repairing the herniated disc so that it's no longer painful and no longer causing back pain or leg symptoms. We're going to get started. Hi there, it's Dr. Deukmedjian. Can you hear me? That's my hand on your back, okay? I'm just feeling around so I can find where I need to go get started, all right? I'm going to give you some numbing medicine as well. That should ease up some of the discomfort. But if you have pain, I want you to say, ouch. That lets me know you're having pain and I can give you some more numbing medicine, okay? I don't want you trying to move around on the table, all right? Are you comfortable? About as comfortable as you can be, right? All right. Well, we're going to get started. You just let me know if you feel any pain, all right? And just tell me if it's your back or your leg. All right. I'm just feeling around with my fingers, so don't be alarmed. So we're going to be doing, again, L3-4, L4-5. That's where the disc that are causing her symptoms are, based on her exam and based on the MRI. You'll feel a little stick and burn, okay? That's normal. I know it's a bit uncomfortable. I'll try to make it as nice as possible, I promise. You're doing great. So we're infiltrating the subcutaneous tissues with the local analgesic. This is just lidocaine, some Marcaine. Same thing the dentist puts on your teeth when they try to do a cavity. It wears off eventually. This stuff will last a few hours. It's long enough to do the surgery. All right, we're going to get started, okay? Now with spondylolisthesis, you really want to try to come in a little higher than the disc level. You want to approach the disc from the top. Just a little bit, maybe 10 degrees. That's some numbing medicine. Do you feel that? Are you okay? Is your neck okay? Shot. All right. Well, this should be a pretty good trajectory. Shot. And we're going to put you to sleep in a little bit, but I need your help in the very beginning, okay? Shot. Shot. Yeah, spondylolisthesis is never easy to treat because you have the facet joints, shot, that are enlarged. And that's what we're up against right now. Enlarged facet joints. Shot. 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 Are you okay? All right. Shot. Shot. Where do you feel that? In your back? What'd she say? All right. So far, everything's going as planned. Your back? Shot. That's you. Uh-huh. All right, shot. All right, let's get an AP. So we're making some progress. This is going to be the more difficult of the two discs to access. And once again, we're not coming straight down on the spine. We're coming from the side. There's a name for this approach. It's called transforaminal. And that's good. Back to a lateral. Now what transforaminal means is trans means across. Foraminal is referring to the neuroforamen. We're on the left side of the patient. So this is a left, and you specify the bones above and below. So that would be an L4, L5. Left L4-5 transforaminal approach. Shot. You're fine. This is the part I can't do much about, shot. Yeah. This is where one of your bad discs are. You okay? I apologize. So we're in like Flynn. Flynn. Remember that next time, okay? In like Flynn. In like Flynn. All right, you were stuck like Chuck. I like that. Very creative. Let's go to an AP just to make sure. So I want to verify I'm happy with the positioning of this needle, AP lateral views on the X-ray. We use the X-ray machine to guide the placement. The X-ray is the most reliable navigational tool when it comes to spine. Now you can see all the arthritis around the facet joint. If you look at that X-ray and the needle that went in, and look at the tip of the needle, just about an inch behind it, you could see all the arthritis on the facets. You're doing great. Are you comfortable? Is that a yes? She's all right. Not as comfortable as a lounge chair or a lazy boy, I imagine. Right? You're doing great, by the way. We've already got one of the navigational markers in. And we're going to be able to put you to sleep hopefully soon. Okay, I just need to get the second one in position, and we're good to go. Shot. All right, so this disc is unlike the one that we already accessed. This one is a little more collapsed, and these are all challenging, by the way, to access. None of them are easy. You feel that? Yes? Let me try to give you some more numbing medicine then. So we can use the numbing medicine here. I don't want to use it down by the nerve roots. You don't want to use any Novocaine or lidocaine or anything like that down by the nerve roots. It will actually numb up the nerve pretty bad. Shot. 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 Oh, I see. Shot. Shot. And honestly, it's the navigation that is the hardest part of the surgery. Shot. That might be okay if I can finagle it. Where do you feel that? Where? Shot. In the back? Huh? Yes. That's your herniation. I'm sorry. I know. Shot. Where'd she say? In her back? Yeah, that's one of your bad discs. Shot. Are you able to give her a little something? Yeah, I mean we're almost there, so I think we're going to want a good discogram, but I need her a little more comfortable. I can't use numbing medicine down here, shot, because the numbing medicine would again numb up the nerves, which we can't have. The nerve going down her leg. Shot? Yeah. Yep, shot. Okay. So we're awfully close, which is good, but we're just not quite there. Shot. Oh, I'm going to try a little bit different trajectory. Shot. Shot. Where do you feel that? All right, very good. You did really good, okay? I'm going to let you just relax for a minute. So, you know, for the viewers that are watching, this is about as good of the needle placement as you can get with this. So learn it, understand it. Accessing the disc is challenging. It's really challenging. And you can see this patient has some scoliosis higher up. She has spondylolisthesis, basically a grade 1 to 2. And she has really enlarged facets. So there's a lot of anatomical things that are working against you, making it harder to go from the surface to the disc. But we did it, and we did it safely and effectively. So at this point, I'll do a little drawing for you. Are you okay? All right, we're going to put you to sleep in just a few minutes. So she has a disc at the bottom called L5-S1, and that's not a cause of her pain. That's down here. So L5-S1. We're not even testing it. We're not doing anything with it. We're leaving it alone. And then she has a bone or a vertebrae, which is the L5 vertebrae. And then she's got this slippage of one bone on the other forward, and that would be L4 slipping forward on L5. Okay, we call that a listhesis. And between the bones is a disc. And then in this disc, she has not just a slippage, but a tear and a bulge, a herniation, okay? And that's what we're targeting with this surgery. The L4, L5 herniation on the left. And then that would be this needle right here. And then we have one more disc up here, which is the L3-4 herniation. And that's the second herniation that I think is a problem for her. So there's a herniation here as well. The L4-5 is bigger, and there's a slippage of L4 and L5. So this level L4-5 has a listhesis. And further up there's scoliosis. We're not treating any of the listhesis or scoliosis, and I expect to get rid of her back pain without doing anything with the scoliosis or listhesis. So many surgeons are just focused on deformity these days. They think the deformity is the cause of the patient's pain, but it's not. As a matter of fact, we could not treat the deformity, and 98% of the time the patients are going to be fine as long as we do the Duke laser disc repair procedure. Okay? Are you comfortable? All right. How bad was that on a scale of 1 to 10? How high did it go? Give me a number, 1 to 10. A 9 out of 10 at L3-4. All right, now I didn't even get any pressurization because it just leaked out. You can see the dye leaked out through a massive tear in the back of the disc called the annular tear, and it's in the epidural space, and it's tracking. But you can see the herniation. Look at the outline of the herniation. Pretty impressive, huh? It's that right behind the disc, which is filled with dye. It's like a clear, almost mammillary processes, and I'm allowed to say that because that's legitimate in Latin. But there are two of them, a double shadow, and then behind that is the dye. So you're actually seeing an outline from the inside of the herniation and the outside of the herniation. Quite impressive. And the needle pierces right through the middle of it. So beautiful. We had a 9 out of 10 pain. And we're going to get ready to do the next one. All right? So the next one is 4-5. And everyone thinks, oh, so 3-4 is a 9 over 10. So this one is a 9 out of 10. Okay? The next one we're going to do is L4-5. This is the one with the listhesis. And this is where our understanding at Duke Spine of back pain exceeds and goes beyond other doctors' understanding. They all think if listhesis needs a fusion, but it doesn't. You don't need to fuse to get rid of the pain. How bad is that on a scale of 1 to 10? How high did it go? You okay? How high did it go? Over 10. So the L4-5 disc with the listhesis was over 10. It was a 10 plus, okay? So this is a 10 plus pain, and the other one was a 9 out of 10 pain. We're going to get started. Now, you're going to go to sleep. When you wake up, that pain will be gone for the rest of your life, as long as you don't re-injure your disc. Count from 1 to 100 out loud for me. Count from 1 to 100 out loud. Nice and loud. So while the patient's counting, we're going to put her to sleep. You'll feel a little burning in your arm. That's just the medicine going in. So what's interesting here, folks, is you talk to spine surgeons around the world in the year 2021, which is where we are, and for the last 20 years, and they're going to tell you patients have pain from their back from spondylolisthesis. That's the slippage of one bone on the other, from the spondylolisthesis. What they don't understand is it's not the listhesis that causes pain. It's actually the tear in the back of the disc, the annular tear. And that, again, is the discovery of myself and Duke Spine Institute. We brought that to light many years ago when we published our original papers in 2012. We talk about treating the annular tear, and that is the source of her pain. Okay? Now, we've only had like 3 drops of blood, so I would say we've had about 1 milliliter of blood loss. If this was an open surgery, such as a laminectomy and fusion, this patient will be losing a lot more blood. She okay? Can I proceed? All right, so I put the guide wire in, shot, and now I'm going to take this needle out, shot. By the way, before we do our last case of the day, everybody here needs to grab some lunch. That's an order. I don't want to hear about people missing lunch. Okay? And we have a nice catered lunch from Nico's here in Brevard County, my favorite restaurant. And we ordered Mexican food. So make sure you grab some. There's also some pizza. Okay, guys, gals, everybody? All right, so there's kind of a double shadow at L5, and that's because the L4 doesn't have a double shadow, just a little bit. So there's actually some rotation. Well, we could probably get L4 less double shadowed. Maybe bring your side up a little bit. Let's try, or maybe down. I don't know. Let's see which way works. Go. I think it may be worse. Let's try the other way. Yeah, that's better. I think that's better. Luis, what do you say? It's better, but it's not perfect. So there's definitely rotation between 4 and 5, L4 and L5. But we're not fixing the rotation. We're not fixing the listhesis, but we are going to fix this patient's pain. Shot. And the reason why is because the pain is coming from the tear in the disc, not the listhesis, not the nerve root. Shot. Shot. Okay. Shot. That's better. Yes. So the interesting thing about listheses is, if you've ever operated on them, one bone is literally much further forward than the other one. The one on top, usually in an anterolisthesis, the one on top. And getting into the disc is weird because rather than there being like two bones here and here that you just go between, one bone is further forward. So you actually have to go in a little bit of an angle, aiming down. That's kind of the secret. All right, now we're going to put our tube in, and for those of you who don't know, this is called the tubular retractor. Tubular retractor. Tubular retractor is just a general term for any kind of a tube put in the body that actually pushes the tissues to the side so that the surgeon can go in and have a path to operate, a way to get in and out and do their thing. Today our thing is to debride the annular tear so it can heal properly, and to decompress the nerve roots so we can treat the patient's leg symptoms. Shot. Just about done. That's beautiful. Shot. Oh, it's perfect. Take.
We have a question from our audience.
Of course, we like questions. Just let me make a few announcements first. I want to do a few PSAs, public service announcements. So for those of you who have never watched our surgeries here at Duke Spine Institute, we've been broadcasting all of our surgeries for the last 8 years. Every week, every surgery that's done. Now, I'm not talking about pain management procedures. I'm talking about spinal surgery. We do far more interventional pain management procedures here than we do surgeries. But we don't broadcast those because they're too quick and too not enough anatomy and stuff is seen. Someday we may actually broadcast those too. We've been broadcasting now for going on 8 years this year. And we broadcast 100% of our surgeries, and we broadcast them live. They're not edited. They're not altered in any way. You get to see things as they really happen. And I think we've made some improvements over the years with the help of my staff like Sean, Luis, and other staff. Zach is now working with us again, and Sonny. These are people that work here that basically are focused on partly on the educational aspect of spine care. And our goal here at Duke Spine Institute is basically to be transparent, show people what state-of-the-art spine care looks like in the operating room, to be able to answer questions and show you what we're doing and how we're doing it in real time. So there's no hiding of things, it's all real. And if I have a complication, you're going to see me handle it in real time. Okay? Fortunately, I don't have many complications. And we take a lot of care and consideration to make sure that surgeries go very smoothly without problems. I do have an anesthesiologist here with me in the room, and he is responsible for putting the patient to sleep, keeping them asleep, and making sure that they have adequate oxygenation and circulation during the anesthesia. My job is to get the surgery done efficiently and safely. So here we are at L4-5, getting ready to get started. The blue stuff is degenerated disc, and the white thing there to the right is the end plate, probably of L5, superior end plate. I will take the question.
So one of our viewers is wondering...
She's wiggling around a little bit. Go ahead, I'm sorry. I had to talk to the anesthesiologist.
That's fine. The viewer from YouTube is wondering what other options exist for back pain other than surgery?
Oh, wow. That's a loaded question. So, first of all, thank you for asking. And it's not a bad question. It's a great question. It's just, it's kind of like saying, what kind of weapons are available besides knives? It's a very, very broad set of answers. But let me simplify it as much as possible. When a patient has back pain, you first have to decide why they have back pain. The cause of the back pain is the most important thing to do. And that's, again, the first thing Duke Spine Institute does better than anywhere is determine why you have back pain. And we've been very, very successful at diagnosing the cause of back pain, okay? But that is number one. Standby laser. You have to know why the patient has back pain. So what are the causes of back pain? By far the most common cause of back pain are what are called degenerative conditions. Degenerative conditions. Degenerative conditions are generally not serious conditions. They're not like cancer or infections. They're basically injuries to the discs or joints that over time become painful and cause problems. Okay? So degenerative conditions account for about 92% of chronic back pain, basically. So over 90% of back pain. The rest of back pain is due to fractures of the spine, like what are called insufficiency fractures, where the patient has osteoporosis and their bones crack under weight, normal physiological loads. That's bad. And the treatment for that is to fix the fracture. Okay, so that's certainly a cause of back pain. It's not a common cause of back pain, but it does happen. Then there are less common causes of back pain, like infection. Thank God it's rare. But like bacterial infections or fungal infections, even less common parasitic infections. So really infections by bacteria or funguses, another cause. And again, extremely rare in the real world. Then there are tumors of the spine that cause pain. So whether it's cancerous tumor or it's a benign tumor, tumors cause back pain. Again, tumors, infections, and fractures are extremely rare when compared to degenerative causes like herniated discs or arthritis of the facet joints. But let's talk for a moment about the common causes of back pain, and those being classified as degenerative causes. Number one, degenerative discs, which are your herniated disc, bulging disc, ruptured disc, extruded disc, fragmented disc, whatever. There's different names. Point is, there's a problem with the disc. The second, facet joint pain. Pain coming from the joints in the back of the spine, otherwise known as facet joints. Okay? So, very common cause of back pain. Another is something called the sacroiliac joint. The sacroiliac joint is like a facet joint, but it's much larger, and it's really located between the sacrum or tailbone and the hips, the hip bones, called the iliac bones. Another cause of back pain that's common is the coccyx ligament, called coccydynia. Another cause is something called the piriformis muscle. It's in the buttock. It's a tiny muscle, it's skinny, and honestly it does nothing but tear and cause misery and suffering for people. It really has no function other than it does cause a little bit of rotation of the hip, but it's unfortunately, as people with back injuries to their discs and facets, they end up suffering with chronic back pain. They become less active. And when you start becoming less active, your muscles start to atrophy or get skinny and weak. And then, believe it or not, they actually become more prone to more injury. So, unfortunately, if you look at how do people treat their back pain today in 2021, most people think, I have back pain, I should become less active, right? Lay on the couch, take it easy. But that's actually the worst thing you could do. So that's why we do this broadcast, is to teach you the right thing. If you go out there and ask 1,000 doctors, I have back pain, what should I do? About 96% of them will tell you, take it easy. But they're wrong. Taking it easy is the wrong thing to do. It only makes your joints and muscles weaker and more painful and more prone to injuries. Okay? The right thing to do is find the source of the back pain and cure it. And that's what we do here at Duke Spine Institute. And we do it literally better than anyone in the world. I'm not talking about myself, I'm talking about the team here of doctors, nurses, technicians, and then of course, Luis. What could we do without Luis? That said, in all honesty, the key here is making the right diagnosis. Once we know the diagnosis, we know the right treatment. Okay? Once we make the right diagnosis, we know the right treatment. You understand what I'm saying? So let's take, for example, because I love analogies and I garner so much criticism for them. Let's take, for example, somebody laying in bed at night, and they wake up in the morning and they have a rash on their skin. Okay, they wake up with a rash and it's painful and itchy. What's the reason? And what's the treatment? Right? So what are the options? Well, one is that the cleaning detergent used for the sheets contains a chemical that they are allergic to. So it's causing a rash on their skin. Another possibility is that they have bed bugs. Little buggies that come out late at night and attack you while you're sleeping. Nasty little guys. Another possibility is that there's a spider coming out and biting you and causing that reaction. Okay? So you're starting to see what I'm getting at. There's a lot of possibilities. Or you got a really weird roommate who likes to do things to you at night while you're sleeping. Okay? Oh. Point is, simply put, if you don't make the right diagnosis of what's causing the rash, you will never fix it. So if you think it's your detergent, and you change your detergent, and the rash doesn't go away, and then you change it again, and the rash doesn't go away, and soon you're sleeping on sheets that aren't being cleaned because you're so paranoid about detergent reactions, and you're still getting the rash. There's something else going on. Don't you? You have to understand that. You're not going to have a solution until you find the cause. And that's what Duke Spine Institute, we do better than anyone, and we figured it out years and years ago. And it's really what sets us apart from all the other spine centers in the world, is that we don't just treat back pain. We first make the right diagnosis, and then we provide the right treatment based on the actual diagnosis. So everyone thinks, oh, you guys are amazing surgeons. Yeah, we are, but more important than that, we're amazing diagnosticians. Okay, and I can't emphasize enough to you how important the right diagnosis to get the right treatment is. And that's really something that most doctors don't have any clue how to make the right diagnosis. And when they do, they don't have the resources to make the right diagnosis. What are those resources? Oh, simple things that you would say, oh yeah, I have that. Like an MRI scan, right? If you get an MRI scan, will you have a diagnosis? And the answer is not necessarily. About 60% of MRI scans are not read properly by the radiologists. They miss the diagnosis. Why? Because they're not looking for the things that actually cause pain. Why? Because they don't know what causes pain. They've never been told what causes pain. And what causes pain is certain things, like fractures, infections, tumors. They can find those pretty easily. But the most common cause of pain in the spine is not a fracture, tumor, or infection. It is an annular tear. And show me an MRI report that mentions annular tears. About 60% of them don't even mention it. Because the radiologist truly has no clue that the annular tear is the cause of the pain. Neither does the surgeons, neither does the chiropractors, neither does most people in the world today that treat back pain. They have no clue the annular tear is the cause of the pain. So when you get an MRI, that's the only way to diagnose an annular tear, or a discogram. And you just saw us do a discogram on this patient, and she definitely has annular tears, and they're painful. One of them was a 9 out of 10, one was a 10 out of 10. Okay? So the annular tear is very important. and it's frequently missed by the radiologist. Missed. Completely missed. So how can you possibly get fixed if the people you're relying on to make the diagnosis can't even make the right diagnosis because they don't have the technology available to them to do that? I hope that drives home the point. You have another question there, Sean?
We do. We have another viewer from YouTube who's wondering, how do doctors get better at diagnosis of back pain?
Yeah, how do doctors get better at diagnosing back pain? It comes down to really, number one, they have to, first of all, believe that they can diagnose back pain. Unfortunately, they're all told throughout their medical school and training that back pain is what's called non-specific back pain, that there's no specific cause. There's no specific cause. I laugh at it now because it's so crazy and ridiculous to believe that there could be pain that doesn't have a cause. I mean, we've been diagnosing and treating it for so long now. The idea that there's no cause is ludicrous, you know? It's absolutely ludicrous. So, but that's the way I was taught as a resident in neurosurgery. That's the way I was taught in medical school. I was taught the same thing they were taught. And then I got lucky that I ended up having a sister who's a chiropractor. And she told me, no, the patient's pain, I would send my patients to her for therapy. And she would say, yeah, your patient has sacroiliac joint pain. And I would be like, what? What is that? I've never heard of that. As a neurosurgeon, I never heard of that. And she'd be like, well, it's inflammation in the SI joint that's causing their pain. And what do we do about it? Well, you do a shot. Get your pain management doctor to do a shot in the joint. Okay, we did it, and guess what? The patient's pain went away. And so it wasn't until after I would finish my training, and of course I went to one of the best training neurosurgery programs in the world. That's why I went there, because it was one of the best. I went to Gainesville, Florida. I studied under Dr. Roten and Fessler and Parker Mickle and Glenn Rectine. I mean, the names, just Jeff Henn. There's lots and lots of names of important people in spine. But none of these people understood that there was actually structural causes of pain in the back. And unfortunately, there's this belief among doctors in training that patients with back pain are faking it. They just don't want to work, or they have a really bad marital situation and they're trying to get out of, performing marital or spousal duties. I mean, this is literally what's taught to you. And you believe it because these are your teachers teaching you. And, they're supposed to be the experts in the world. And, of course, they teach you that back pain cannot be cured. There's no source. So, of course, you can't cure it. So I kind of believed it when I graduated, and it was only because of my sister, who's a chiropractor, who taught me differently. Because chiropractors treat pain, right? And they're happy to do it. But the problem is chiropractors can't fix all sources of pain, because some sources of pain require surgery. And chiropractors are not surgeons, though there are some who think they are, and they like to do surgery without, being caught doing it. I've seen this down in Palm Beach area. But the point is this, it's simple. You have to make the right diagnosis. Once you understand the structures that cause back pain, then you learn the treatments. Like, what is the right treatment for that? Once you know the right treatment, you either can do it yourself because you're trained to do that kind of surgery, or you refer the patient to someone who can. Okay? So, for example, at Duke Spine Institute, all the causes of back pain and neck pain we treat here, no matter what that cause is. Now, we don't advertise ourselves as being spinal infection treaters, Because somebody with a spinal infection should not be traveling to Duke Spine Institute to get their infection treated here. You need to stay in the hospital by your house, and you need to have antibiotics. And that's the right treatment. You don't need to come to Duke Spine to get antibiotics. And you need antibiotics for like 6 weeks to 3 months, a minimum. So we're not the right place to be administering antibiotics. So what I'm getting at is everybody with back pain needs a diagnosis. And then based on the diagnosis, they need the proper treatment. And that should be readily available. How do you fix the problem? Step one, get doctors to understand they don't know. They don't have all the answers. But there are answers out there. They just need to learn. And that's one of the hardest things you're ever going to do, is get doctors to admit that they don't know something. Okay? I hate to tell you it. I'm a doctor. But it's just true. Doctors don't like to believe or admit that they don't know something. It's called ego dystonic. If you know what I'm talking about, ego dystonic thoughts are thoughts that make people feel like there's they know that there's something wrong with the way they're doing things. They create dystonia, basically bad feelings, okay? So when you do things or you behave a certain way that you know is wrong, then it creates anxiety. It's all very Freudian stuff, by the way. Creates anxiety, and anxiety creates unrest and stress. You know, Freud believed anxiety was the cause of everything bad in the world, in humans. And to a degree, he was right. So doctors don't like to admit they don't know everything, and therefore it makes them uncomfortable, like everybody else. And therefore, the first step is in fixing the problem is getting doctors to be trained properly in their residency training program in medical school, where they are accepting, where they're in a situation of education where they're there to learn. They're there because they don't have the answers. They're there to get a degree. And so if you teach doctors in medical school the causes of back pain and the treatments of back pain, then you will win. And we can start really focusing on getting patients the medical care they need to get rid of their back and neck pain. So it really comes down to medical school, and then the next level after that would be residency training. You know, they need to learn in residency that there are causes of back pain, specific causes that are structural, and they need to be able to identify it, which is pretty easy to do. I could teach them. Grab her. And then they need to send their patients to the appropriate doctor that can fix the specific cause that they've diagnosed. Okay? That's the key. I hope that answers your question. Okay, we're just about done here. I started with the harder one because that's just my nature. I always like to get the hard stuff done first and then do the easy stuff later. I come in with the guns blazing. How's our irrigation? It's looking a little weak. What do you think?
We have another couple questions.
You have more questions. All right, let's take them.
A viewer on Facebook is wondering, does the removal of the herniation cause movement between the vertebrae?
Does the removal of the herniation cause movement between the vertebrae? That's a really good question. I think there's a piece of herniation, by the way. Let's show them what I just fished out. Can you guys see this, Sean? Look at the size of that thing.
The light is a bit overexposed. I'm zooming in on it. Yes, we can see that.
Can you see that massive herniation? So that was kind of hiding behind the in the side of the disc, to the side, and that's one of the herniations I shoved in when I put the dilator in. I kind of pushed it in, so now it's gone. Things are looking good. All right, I apologize if you don't mind just repeating that last. By the way, there's the nerve root right there. See it? At 9 to 11 o'clock. That's a dura, the covering of the nerve root. It's got some little veins on it. That's called the dorsal root ganglion. It's coming out of the spinal canal. So we're done here. And I'm sorry, Sean, if you could just repeat the question one more time.
Yes, the viewer was wondering, does the removal of the herniation cause movement between the vertebrae?
Yeah, okay, so sorry. So let me rephrase the question. Does the removal of the herniation cause movement between the vertebrae? So the vertebrae are the bones, right? They're called vertebral bodies above and below the disc. The disc is what's damaged. It's really a joint between the vertebrae. So just so you understand, it's normal for the vertebrae to move with respect to each other. That's how we bend and twist in our backs. When you bend over to pick something up, when you twist around like you're throwing a frisbee or sweeping, that sweeping motion or twisting motion of your waist is movement that's happening between the vertebrae in your lower back. Okay? So bending, twisting are movements that normally occur between the vertebrae. So yes, vertebrae normally move with respect to each other. Does removing the herniation somehow alter the movement? What I found is that when patients have a herniated disc, like these ones we've been fixing all day, their movement between the vertebrae is reduced. It's reduced. It's less than normal. When we take the herniation out and we clean up the annular tear and debride the annular tear, the movement goes back to normal. So the Duke laser disc repair surgery that we're doing right now actually gives the patient back normal movement between those vertebrae, whereas the disease state of herniation with annular tear takes away movement. Okay, we ready to take this out? Sorry, I thought you already got it. Thank you, Luis. So let me say a few more things while I have your ears and eyes. Aside from live streaming our surgeries at Duke Spine Institute, we also have a Duke Spine Institute app for the iPhone and for the Android. The app is free to download. There's no charges whatsoever. And it's an educational app. It's there for you to learn. It also has links to common types of spine surgeries, laminectomies, fusions, anterior cervical discectomy and fusion, posterior cervical laminectomy and fusion, Duke laser disc repairs, endoscopic surgeries, pretty much all types of spine surgery for degenerative conditions. We have them on the app. You can watch surgeries. You can also see patient testimonials, learn more about advanced treatments offered here at Duke Spine Institute. And of course, we have a library of disease conditions affecting the spine and treatment. So you can really learn a lot on the app. You know, it's interesting, all of our patients that come here, we have them download the app in the waiting room and shot. And then what happens is while they're here in the room, we make their diagnoses through the physical exam, the MRI, etc. And then we actually we load those diagnoses into their app on their phone, so that when the patients leave Duke Spine Institute, they actually have a record of the diagnoses that we've just made that day. Go ahead. So, and the treatments that are recommended for that diagnosis. I also want to draw your attention to the fact that there is a Facebook group that Duke Spine Institute supports. It is called the Spine Surgery Support Group. Again, it's a free group to join, and anyone around the world is welcome to join it. It exists for the express purpose of sharing information and ideas about the spine and spine care, and whether or not you've had surgery. You don't have to have surgery to join the group. If you have a question about the spine, like what kind of questions we're getting today, you can always join and ask those questions. Okay? We hope that it's a useful tool. It's like an interactive forum, and it's on Facebook, so it's a good social media platform most people have. Spine Surgery Support Group, asked to join today. We have lots of interesting posts, lots of interesting comments. We try to keep everything real and true, and we don't allow advertisements shot, except our own, of course. Should put a smile on a few people's face. We're getting ready to do the second disc for today. This is the L3-4. There's no listhesis here, but there is scoliosis. And you can see the guide wire is inside the disc. I'm going to pull it back just a little bit, shot. And I'm advancing now the dilator. You've gotten pretty good at managing the anesthesia for these. Seriously. Huh? Yeah, you've gotten pretty good at it. So I need to aim up a little bit and shot. Take. Nope, not ready yet. I want to advance this just a little bit more. Shot. And a little bit more. Okay. Perfect. I'm going to, again, for those of you who have not seen this yet, this is the whole surgery is done through a tube. We call it the tubular retractor. You see that, Sean?
Yes, we do.
Yeah, it's 7 millimeters side to side. So 7 millimeters, very small incision that needs to be made. It's a Band-Aid incision. It's actually the smallest incision in spine surgery. There is nothing smaller than this. Of course, you could do a needle procedure, but this is not needle surgery. This is real surgery. And real surgery requires an incision. And once again, this is the smallest incision in spine surgery. I'm using my X-ray machine to watch the advancement of this tube into the disc. And I want to make sure I don't go in too far. All right, I want to go in just the right amount, and that is the right amount. Good job, Jordan. Jordan has joined us. Did you get something to eat? Yes, sir. Good. Was it good? I found that the chicken burritos have a flour tortilla, which I like better. Unfortunately, the beef ones have a corn tortilla, and they're just falling apart. So I'm going to have a talk with Nico. But the taste is amazing. All right, if you're a nurse out there watching, we are hiring nurses right now. So if you want to move to Florida and live on the beach, come on down. I will tell you, though, we only take nurses dedicated to helping patients overcome pain and illness. So if you're motivated by helping other people get better and you love that kind of work, I think you'll fit in perfect here. All right. By the way, my mother's a nurse and my sister's a nurse, in case you're wondering. I love nurses. Sometimes they don't appreciate my love and respect for them, only because I have to be tough on them when they make mistakes. Everyone makes mistakes from time to time. The goal is to minimize those mistakes and not let them hurt others that you care for. As such, I frequently find myself talking to my employees, trying to improve their performance so that it doesn't result in additional pain and suffering of my patients. But sometimes people don't understand that. Anybody know what the cause of the bubonic plague was? Anybody? Anybody know what the... Let me back up. How many people died from the Black Plague or bubonic plague? I need a statistic here, Sean. It was the biggest loss of life back in the medieval times. It was the Black Plague. How many people died in the Black Plague, bubonic plague? Sean? Are you there?
I am searching for you right now. It looks like it was about 30% of Europe's population, which is
30%.
about 25 million people.
25 million people. 25 million people died of the bubonic plague. What year was that?
It was in the 1300s and 1400s.
1300s and 1400s. Hey, almost, what? Almost 1,000 years ago, right? How many, huh? Of course it is. Smart. That's right. So, one of my nurses, very smart, and on top of things, it is a disease caused by a bacteria called Yersinia pestis, and it's transmitted by what? Rats. Rats. No. The Black Plague in Europe, you're not understanding. When the Black Plague was going on, there were no prairie dogs living in London. Okay? The reason why it happened was because there were so many dead bodies in the streets and there was so much garbage in the streets. So rats were breeding like crazy. Without the rats, there would be no bubonic plague. Yes, Yersinia pestis existed, but without a mechanism or vehicle, it couldn't have caused so much death and damage. Right? So if you went after the rats, what do you think the rats were saying? Hey, I'm just a rat. I'm just a rat. Why are you bothering me? Right? I'm just eating food. Yeah. But the problem was that little animal, as innocent as it thinks it was causing the greatest outbreak of death up to that time.
We have another question.
Yeah.
We have a viewer on YouTube who's wondering.
I want to say one last thing. I want to complete the circle before we get our viewer on YouTube comment. Why did I bring up the little rats and the death that they caused? Because the rats had no idea they were causing that much death and destruction. They didn't do it intentionally. You understand the difference? When Hitler invaded Europe with his armies and his weapons of death and destruction, he went with the express purpose of, well, being victorious, but he had the intent of killing people and harming people. And it happened. Okay? The rats that killed as many people as Hitler, if not more, they did not go with the intention of killing people. Yet that was the effect. What's the difference between the rats and Hitler? It's simple. Hitler's killing of human beings was for ambition and power, control. The rats had no idea they were killing people. And that wasn't their intention. They were just there to eat food. So it doesn't matter what the motivation is, the effect was the same. What I'm getting at is people can do harm when they don't realize they're doing harm. So it's important to always assess what you do and the effects of what you do and what effects it has on others. Okay, be aware of that. You don't have to have bad intentions to cause harm and death and destruction. It can happen even without bad intentions. Okay, we'll take the question.
So we have a viewer on YouTube who's wondering, how do you know which disc material you'll need to remove once you're in with the endoscope?
How do I know what disc material I need to remove once I'm inside with the endoscope? That's a great question. A great question. Well, the truth is that when I get into here with the endoscope, I'm actually inside something called the annular tear. And so around the walls of this tube, the silver tube in front of you, around its walls is the annular tear. And that's what I'm here to debride. So I know that as long as I put the needle in properly and the guide wire has done its job of guiding my instruments through the annular tear, that I will be entering the disc in exactly the place that needs to be repaired. The annular tear. That's one of the amazing things about this surgery, is that the exposure, what we call the exposure, where the surgeon gets into the body, into the area that needs to be repaired, the exposure exposes exactly what needs to be fixed. It's right in front of you. So that's the beauty of it. I can see the tear. It's here. And that's what I have to debride. I can also see fragments of herniation, like this thing that's bubbling up just below there. That's a piece of disc herniation. And the reason it isn't coming out, it's not just floating out, is because it's stuck to the annular tear. And that's the whole thing about this condition, this disease, is that the herniation cannot release from the annular tear because it's scarred down to it from years of scarring and inflammation. And that's what I have to remove. Grabber. Whew. All right, so we're about to finish with this patient, and then we're going to do one more patient next, a single level, one level. I don't remember which level it is, maybe L4-5, I'm not sure. We'll find out when I go see the patient. L3-4? You could be right. By the way, in case you're wondering, this patient herself actually has more than 2 bad discs in her lumbar spine. She actually has 5, but we're not fixing all 5 because the other ones I don't believe are causing as much pain as these 2. These 2 are the main ones. We've already seen from the discogram that they caused 9 out of 10 pain and 10 plus out of 10 pain, right? So I know for sure these are 2 discs that are causing a lot of pain. By the way, over there, that white thing over here is the end plate. It's the vertebral body, the surface of the vertebral body. And this here is the last of the annular tear. I'm sorry, the last one is L2-3, you're sure? It's an unusual level. Oh, yeah, I wonder if they have a far lateral herniation. All right. Those are great questions so far, Sean, from our audience. Does anybody else have a question?
Not currently.
Okay, we got about 5 minutes and we'll be done. This is so scarred up right here. The more scarred tissues are, the denser they are, the harder they are for the laser to do its magic. I'm just having a hard time, Luis, getting the laser to where it needs to be. It's a little better, yeah. But you can see the laser energy being delivered to the tissue, yet the tissue is not vaporizing as easily. And for those of you who missed the last surgery, we had a really good discussion about comparing scalpels to lasers and how much more precise a laser is than a scalpel. Plus, laser fiber doesn't get thrown away every case like a scalpel does. The laser fibers are usually reusable, and therefore, you know, unlike a scalpel, you're actually more green with a laser. You're saving waste and saving the environment. Scalpels have to be melted down after they're used in incinerators, which an incinerator, if you've ever seen one, is extremely hot. It melts things. So biohazardous waste usually ends up incinerated, where all the bacteria and viruses are vaporized in flames. So what I'm getting at is a scalpel is an expensive instrument to dispose of, whereas laser fibers is not. We reuse them. So when people compare, when they hear surgeons, people talking about laser surgery, and they're bad-mouthing the laser, which there's lots of articles online about that, they're all full of nonsense. The doctors that write about laser being not effective or not better or being a gimmick, they're the ones that don't use a laser. They don't know how to use the laser. It's not that what they're saying is true. It's that they've never used a laser. They're just lashing out. It's kind of like a little child, you know. Like yesterday, you know, or not yesterday, but I guess a while ago, when one of my children did something bad, okay, we would take their phone away as punishment, okay, and you know what they would say? They would say, "You're the worst dad in the world." Right? You're the worst father in the world. Okay, of course I'm not the worst father in the world. Maybe second worst, but not the worst. But the point is they're lashing out. They're trying to be harmful and hurtful. But what they're saying is there's no supporting evidence. It's just made up. It's made up for the express purpose of hurting somebody. These doctors that publish about laser spine surgery and how laser doesn't, you know, is not even as good as a scalpel or no better than a scalpel, they literally are just crying out like a little baby because they don't know how to do laser surgery, and they've never been taught, and they don't know how to do it, and all they're doing is kind of old-fashioned surgeries that they know one day are going to go the way of the dodo bird. And so they're just lashing out. You can't believe anything they say. It's nonsense. Laser is a far better tool than a scalpel. Far better. Far more accurate, far safer, and of course I already pointed out that it's green. So Joe Biden should really like lasers in medicine because it's green. Green technology. Okay? That's just my 2 cents. I use both. I use lasers and scalpels both. We're done. How do I know when to stop? That's years of experience. I can't teach that to you over a microphone. All right, let's take a look at what we've done here on this particular patient. She had 2 discs that had annular tear with herniation, and one of them actually has listhesis, spondylolisthesis, where the bones are sliding on each other, okay? I'm going to put a little bit of pressure on the incision. Really, it's not the incision I'm putting pressure on, it's the muscles just under the incision. This is to keep any kind of bleeding from happening internally by putting some pressure here. We're going to give it just a couple of minutes as the walls of any blood vessels will clot off. Let me just show you, Sean. You guys ready?
Yep, we're watching.
All right. So the whole surgery was done with a 7mm incision right there. And we diagrammed the discs that we tested. Again, this was at L4-5 with the listhesis. It was 10 out of 10 pain, 10 plus. And then the L3-4 was 9. So we're going to put a Band-Aid there and we're going to be done. And like I said, we have one more surgery. Everybody in here has to go have lunch, okay? Just, it's okay if we delay for 10, 15 minutes. You guys go eat, kick up your heels for a few minutes. You're welcome. I don't ever want to be accused of running a sweatshop. Right? Not in this room. It's nice and cold. I won't let you sweat. How's that? All right, go ahead and type up your questions for me, and I'll head over and we'll do a quick interview on the camera. Good work, everyone.
All right, everyone, Dr. Duke will be joining us in the room shortly for the post-op Q&A. If you have remaining questions, go ahead and type them up in the chat now.